Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone. I'm Carol Fleck, and on behalf of the Attitude team, I'm pleased to welcome you to today's ADHD Experts presentation titled ADHD, Pregnancy, and Motherhood, a Practical Guide for Hopeful Parents. Leading today's presentation is Dr. Allison Baker. Dr. Baker is a child, adolescent, and adult psychiatrist with the Perinatal and Reproductive Psychiatry Clinical Research Program at Massachusetts General Hospital with an appointment at Harvard Medical School. She is a clinician, researcher, and educator with expertise in pediatric obsessive-compulsive disorder, adolescent mood disorders, perinatal psychiatry, and ADHD across the reproductive life cycle. Dr. Baker frequently lectures and leads workshops on a variety of topics in child and perinatal psychiatry. In today's webinar, we'll discuss how ADHD symptoms appear to strengthen in women during pregnancy. And that brings up the all-important question of whether women should continue to take their ADHD medication while pregnant. Is it considered safe, or should they discontinue use? And if so, what are the consequences of that decision? Dr. Baker will share the latest research to help you, your partner, your patient, or your loved one make informed decisions for the best outcomes. We'd like to begin today's webinar by asking this poll question to our live audience. Which of the following ADHD-related challenges has had the biggest impact on your decision to become pregnant? Please select your answers and comment in the text box under the video player to tell us more. You'll see the poll results when you submit your response. And while you do that, I'll point out that live participants may submit questions anytime during the live event. To download the slides, click on the Event Resources section of your webinar screen. If you're interested in the Certificate of Attendance option, look for instructions in the email you'll receive about an hour after the live broadcast. A transcript of today's event will be made available in the coming week. If you're listening in replay or podcast mode, visit attitudemag.com and search podcast 454 to access the slides, the video replay, the Certificate of Attendance option, and the webinar transcript. And if you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe. Sign up now to receive Attitude Magazine's summer issue, where we celebrate moms just in time for Mother's Day. We know how much she takes on to care for her family, so we've included a self-care guide for her well-being. Our summer issue also includes results from a new Attitude survey on how hormonal fluctuations from puberty and pregnancy to menopause and andropause affect ADHD symptoms in women and men. You won't believe the decisions it drove some women to make, and men said they made some pretty dramatic decisions too. And if you're looking for natural approaches to augment your child's ADHD treatment plan, you'll want to read about the vitamins and supplements that can ease ADHD symptoms written by a clinician. Sign up for Attitude Magazine for your family or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Finally, the sponsor of this webinar is Inflow. Inflow is the #1 app to help you manage your ADHD. Developed by leading clinicians, Inflow is a science-based self-help program based on the principles of cognitive behavioral therapy. Join Inflow today to better understand and manage your ADHD. Click the link on screen to learn more. Attitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. So without further ado, I'm so pleased to welcome Dr. Allison Baker. Thank you so much for joining us today and leading this discussion.
Thank you so much, Carol. And it's such a pleasure and treat for me to join you today for our webinar. the timing is not lost on me that here we are in Mental Health Awareness Month and just a few days before Mother's Day, as you alluded to, Carol. So the timing feels just right. And I wanted to start by sharing that in my lifetime, I've gone from seeing the evolution of ADHD in girls and women as not existing to a present day closer to a tidal wave of interest and awareness and ultimately acceptance of ADHD in girls and women, which is appropriate and exciting and an opportunity. So I hope that you all get what you're looking for from today's webinar. By way of background, I thought I'd just lead with this data point from the National Comorbidity Survey showing about 4.5% of United States adults of having ADHD, and of these, 38% are women. So that translates to roughly 1 in 30 women as an appropriate estimate of ADHD. As you may or may not know, it's exceedingly well documented in the literature how ADHD is linked to elevated risk of poor general and mental health, increased rates of substance use disorders, impaired work performance, and financial distress, and all of the above was well documented and historically been the research interest of the wonderful and late Joe Biederman, and that ADHD is strongly associated with other mental health disorders such as mood and anxiety disorders. It gets complex diagnostically because disorders and disabilities exist within and are influenced by social and biological context. So I came up with this graphic representation just to touch on the various considerations as we tease apart a complex presentation. Given that men and boys are diagnosed far more commonly than women and girls, and why is that the case and what can we do about it? Well, we know that girls are biologically different and live in a society where still today expectations are different for males and females. And despite the gains made in terms of increasing diagnoses of ADHD in girls, challenges remain. A lot of this is about sort of long-standing male-based diagnostic criteria that are slow to change. And consequently, current research is somewhat limited in its ability to contribute to a greater understanding of ADHD in females if we strictly adhere to standardized and normed rating scales today. Most studies do align that girls with ADHD show fewer behavioral or conduct problems than boys, but again, this leads to lower rates of teacher referrals even today. And likewise, there's a general consensus across studies that girls with ADHD are more likely, or rather are less hyperactive, more likely to be inattentive. But in my experience, I think a more nuanced understanding of what is hyperactivity as it presents and manifests in girls is worth considering. Facets of emotional excitability or reactivity of mood that I think historically has been put under the heading of a mood disorder may well be a representation of that domain, specifically hyperactivity. And yet it's harder to quantify than, for example, how many times do you leave your seat when remaining seated is expected. The bottom line is that girls may show fewer or different symptoms, but likely to be just as impaired. And then, of course, another diagnostic consideration is the tale as old as time, that girls with ADHD tend to internalize criticism they receive from peers and teachers and parents, leading to a strong motivation to minimize or mask symptoms. This, however, can generate a lot of shame and self-blame that persists to the extent that studies of adult women with ADHD report they struggle significantly more with negative self-image than men do, despite no reported differences in impairment between men and women. And a little preview, we saw that reflected in our data when we looked at acutely postpartum women with ADHD, statistically significant increase in sort of negative self image and self-representation. So my goal today is to help women with ADHD and their family members, their loved ones, their partners, considering or currently in motherhood, to understand that the path to success and satisfaction in your life, it really includes understanding yourself and seeking and creating an environment that is a good match for you and your unique self. And I hope to be able to provide specific resources and references to help you achieve that goal. I'm going to just advance the slide. So ADHD in reproductive age women, it's important to note, which we've just touched on, that it has been associated with a lot of comorbidity. So increase in depression and anxiety and substance use, and impairment in occupational and social functioning. We also know that adult women with ADHD can experience a variety of difficulties at work and in their personal and family lives related to their symptoms. So given that the treatment can improve functioning and quality of life, women currently on treatment may wish to continue their medicine and other facets of their treatment during pregnancy in order to continue to experience the benefits. I've put together a sort of women-focused or ADHD in pregnancy and motherhood-focused multimodal treatment representation, just to touch on all the various ways in which I think we can optimize treatment of ADHD in women, in perinatal women specifically. And that includes medical and educational and behavioral as well as psychological interventions. So when I'm evaluating a woman in the perinatal period with ADHD, especially as she's planning pregnancy, I like to be able to touch on these various parts of a management plan and try to individualize one that makes the most sense for her and for her needs, because personalized treatment is key to meeting her individualized goals. And I would say the optimal management of ADHD process should always include input from family and partner, thinking about work considerations, making certain non-pharmacologic options have been explored or leveraged, including exercise, executive function coaching, cognitive behavioral therapy, dietary intervention. How does she fuel herself? Has she ever experienced or had the opportunity to receive instruction in organizational skills training? What workplace supports could be considered during pregnancy, especially if there's a desire to decrease medication or stop medication? Has she ever explored mindfulness-based practices to decrease stress, as well as enhance benefits of attention and focus? And then, of course, pharmacological therapy, which is a mainstay of the treatment, and one that we have a lot more data on today than we have before in the past. And increasingly, there's more and more data coming out, which is very helpful and reassuring. On the topic of medication treatment, I've just included this and then the next slide as well, which is a really helpful resource that you can download for free. It's the ADHDmedicationguide.com with permission from the author. And it's updated routinely and just as a really, I think, nice graphic visual representation of the different medications that are currently on the market for ADHD, and can often be helpful as well in taking a history. If someone recalls having been prescribed a yellow and white capsule, but couldn't remember the name of that particular molecule or derivative, this is a nice way to enhance the history taking. So these are all of the methylphenidate derivatives, both long and short acting, as well as then the amphetamine derivatives, both short acting, immediate release, as well as long acting, extended release, and then the non-stimulants. So this is available online and is free and downloadable. So for clinicians and individuals alike, this can be an incredibly helpful resource. So given that ADHD medication use among pregnant women is increasing, and to date consensus about the safety of the medication is lacking, it's an important topic for today's webinar. And given that nearly half of the United States pregnancies are unintended and early pregnancy is a critical period for fetal development, these are matters of great clinical and, I would say, public health importance. I included this slide just to bring sort of the issue to the fore, because the picture really does tell this story that this CDC data looked at a period of 2003 to 2015, so already several years outdated, to estimate the percentage of women ages 15 to 44 years old, so women in sort of the reproductive years, who filled prescriptions for ADHD medication each year. So it's really, notable to see how that number increased dramatically, and I think is why there's more interest and also more data available today, because the demand is there, and now we have the data to retrospectively examine impacts of medication use during pregnancy and how that informs obstetric and pediatric outcomes. So how safe is the use of ADHD medication during pregnancy? This is a question that we get asked in our clinic a lot. And so I put together a chart to summarize what is actually a fairly robust list at this point of large studies looking at both methylphenidate, or not just both, methylphenidate and amphetamine derivatives, as well as other medication options for the treatment of ADHD, including bupropion, atomoxetine. There's some data, far fewer data for the non-stimulants, but not zero. So research indicates that, stimulants, so specifically methylphenidate and amphetamine derivatives, are the most effective course of treatment in most instances. And so during pregnancy, such treatment also exposes the fetus to these medications. And so several studies that I've outlined here in summary have set out to determine whether such exposure is harmful. The largest methylphenidate data covers a lot of ground. There were 2 studies with a combined total of 402 exposed infants that found no increased risk for malformations. Another with 208 exposed infants found a slightly greater risk of cardiovascular malformations that was not statistically significant. A 4th study with 186 exposed infants found no increased risk of malformations, but a higher rate of miscarriage. A 5th study with almost 500 exposed infants also found a higher rate of miscarriage, but the 6th study with 382 exposed infants likewise found that risk, but also found an identical risk in women with ADHD who were not currently taking medication. So in other words, could it be that the risk for miscarriage was carried with the indication for the treatment, so the disorder itself, as opposed to being secondary to the medication exposure during early pregnancy? Then there was a scoping review and meta-analysis of all the observational cohort studies that compared malformation rates among babies exposed to methylphenidate during early pregnancy to the rates in the general population. And so that meta-analysis included 4 cohort studies and had almost 3,000 women exposed to methylphenidate only, which in conclusion showed that methylphenidate exposure in early pregnancy is associated with a small but significant increased risk for potentially cardiac malformations. But what that means in practice is that the absolute number is still quite low. And one way to thread the needle, which is a phrase that you'll hear me repeat today, is to consider potentially a first trimester cardiac ultrasound for women continuing methylphenidate during the first trimester. But again, overall number, the absolute risk is quite low. Then in amphetamines, there are over 5,500 data points. And the bottom line is that it is not a major teratogen. It used to be thought in general that ADHD in pregnancy was something that just we couldn't treat with medication. And so, as I've discussed today, and as Carol had mentioned, it is now increasingly recognized that this is just not the case for many women. And for certain women with risks of their untreated ADHD, including motor vehicle accidents, and also significant impairment in functioning, both in occupational and domestic roles, including also not being able to access prenatal care for a healthy pregnancy. It is not an option to just say, stop your medication and good luck. And nor is it necessarily indicated given this overall very reassuring summary of all the different reproductive safety data. Very recently, so earlier this year, there was a study that came out also looking at neurodevelopmental outcomes. This is incredibly helpful because to date, we would meet with women in the consultation office and talk about the methylphenidate data and the amphetamine data or the bupropion data, and talk about risks, potential risks of obstetric complications, or what were the risks of any kind of birth defects or congenital malformations. But we just did not have any data about neurodevelopmental outcomes, like how did these babies do in terms of being exposed to these medications during pregnancy, and then how did they fare on different metrics, including rates of autism, ADHD, and other neurodevelopmental impairments like visual and hearing impairments, growth impairments, likelihood of epilepsy, and any other developmental impairments. And so this paper that came out, I think January or February of this year in Molecular Psychiatry was very reassuring. It was a large population-based study and demonstrated no differences in rates of ADHD, autism spectrum disorder, cerebral visual or auditory impairments, seizure disorders, or restriction in growth when compared to children who were antenatally exposed to ADHD medication with children whose mothers discontinued their ADHD medication prior to pregnancy. So this rounds out our discussion of weighing the risks of continuing medicine with the risks of discontinuing medicine. So this summary slide is meant to help us just sort of more broadly speaking, make the following conclusions. So while some studies have shown increased adverse effects among infants exposed to maternal ADHD medications, most have not. And there are indications that higher rates of miscarriage are associated with maternal ADHD rather than fetal exposure to stimulant medications. While one study did find a small increased risk of central nervous system disorders and admission to a NICU, again, we do not know necessarily whether that was due to exposure to the medicine or associated with maternal ADHD. So in summary, it is safe to say that none of the medications used to date, including methylphenidate, amphetamine derivatives, and bupropion for the treatment of ADHD are major human teratogens, which is really reassuring. Amphetamines may increase the risk of preeclampsia, which is an increase in your blood pressure during pregnancy, and possibly other gestational outcomes. But again, the absolute risk is low. So what that means in terms of clinical significance is that if in a study you see statistical significance, it's then helpful to put it into context of just the general population. And that's where absolute risk is a very meaningful outcome. So even though there may be an increased risk in preeclampsia, monitoring blood pressure at your OB visits is sufficient, and that the absolute risk of it happening is quite low. Long-term neurodevelopmental studies on the offspring born to women taking stimulants, ADHD medication during pregnancy are newly available, as I alluded to a couple of slides ago. And at the same time, we need more data. So we need to continue to track outcomes and follow these women and their children prospectively to help increase our database. And when choosing or considering medication during pregnancy, methylphenidate, amphetamine, and bupropion appear to be better choices than other medication where we just don't have as much reproductive safety data. So that's what I alluded to when I was mentioning some of the non-stimulants like clonidine and guanfacine. So if there is a risk, it appears to be a small one. And then the question really becomes, how do we balance that as yet uncertain risk against the disadvantage of discontinuing effective stimulant medication? So when considering pregnancy and ADHD, it's important to think through different facets of the decision-making, including it's possible that during the perinatal period, there's an impact on your ADHD. For example, hormonal impact on your cognition and increased likelihood of being distracted. No studies when I had set out to do this work had evaluated the course of ADHD during pregnancy and the postpartum. Treatment decisions, of course, are impacted by pregnancy, and many women elect to discontinue their stimulant during pregnancy and while breastfeeding, but that isn't necessarily the most sort of effective choice for overall wellness. So just briefly to review our study looking at the course of ADHD during pregnancy, we had hypothesized that risk for ADHD symptom severity and functional impairment would be higher for the women who decided to stop or change the dose versus those who continued. And so we recruited women who were pregnant, aged 18 to 45, and then we followed them prospectively through their pregnancy using 3 structured clinical interviews, assessing ADHD symptoms at each time point using the AISRS. And we also assessed other outcome measures, including anxiety, depression, a perceived stress scale, and a functional impairment, the Weiss Functional Impairment Scale. And so it was really interesting, and we were talking before this webinar about this particular study. So this is what we call a naturalistic or observational study where we had no say in what women did because that would not be ethical. Rather, women participated in this study and continued to work with their outside clinician, making a decision about what would make the most sense for them during their pregnancy. And so of the 45 women who had enrolled in our study, 14 of them discontinued their medication, 13 adjusted. So if they were typically, Monday to Sunday, an extended release stimulant user, they then maybe switched to a short acting, or they used it just on days in the office versus weekends. And then a total of 18 of those women just maintained their pre-pregnancy regimen. It was interesting and validating to note that in our particular study, the comorbidity was significant, and that really tracks with and mirrors what we know about studies of ADHD in women, that this is a highly comorbid or co-occurring psychiatric disorder, along with high rates up to 50% of women with meeting criteria for generalized anxiety disorder, major depressive disorder, as well as some other mood and anxiety disorders. And so our results, interestingly, in terms of the AISRS, was that there was no difference in pregnancy in terms of the AISRS scores across the sample, regardless of treatment condition. Of course, these were not true treatment conditions. They were just groups of women, organized according to what they did with their medication. So in other words, it didn't matter what they did with their medicine. Their ADHD symptoms during pregnancy didn't change, but what did change and was statistically significant were self-reports of functional impairment for those who discontinued their medication, and also their depression rating scale. And so this can be a little confusing because it says postnatal depression scale, but this is a depression rating scale that we also use antenatally or during pregnancy. And so for the women who discontinued their stimulant medication during pregnancy, you can see in this blue line, their EPDS score was statistically significantly elevated at the time point of the third interview, which is around 36 weeks gestation, as compared to the other two groups, either those who continued exactly as they had pre-pregnancy versus those who switched to maybe an as-needed model. Their EPDS or their mood, their depression rating scale remained the same. So what does this actually mean? What are the kind of clinical implications of this study? Well, we had no systematic studies prior to that in terms of looking at sort of what happens during pregnancy. So it was helpful in terms of advising women when they're considering pregnancy. And despite reassuring data on reproductive safety, historically, we had often recommended just stopping medication and if it would seem that the woman would be able to function well enough without her stimulants. So this was very helpful data to round out that clinical discussion or that risk analysis, the threading of the needle, because it helps us understand that the course of ADHD during pregnancy highlights that there may be specific vulnerabilities to mood symptoms roughening, which can in turn impact development of the baby, as well as functional impairment. So very helpful and important to consider when thinking through risks of stopping medication versus just the risks of exposure to medication. So then the transition to motherhood. And I really just love this particular illustration because I think it conveys the incredible challenges, the unique and at times burdensome responsibilities, and so it goes without saying that motherhood is a multifaceted and challenging time. And as a woman's responsibility increases in motherhood, psychological distress can increase as well. And often distracted from her own self-care, a woman with ADHD will often postpone checkups and procedures for herself and kind of just function with serious sleep deficits. Inconsistent eating patterns, which can be part of the disorder, as shaped by inattention and impulsivity, can result in complications. And all of the above can lead to chronic stress, wherein there might be more dependence on medications, not just for ADHD, but also to manage comorbid anxiety and mood disorders, sleep challenges or pain, and in turn increase vulnerability factors that lead to substance use disorders. As women mature, they learn to appear less symptomatic. Sort of that was, what I was trying to touch on in our very first graphic representation of different diagnostic considerations. But this end is often kept close to the vest. Women may distance themselves from their friends, and they may hide their struggle and their suffering from their partners. And as a mother, when a woman is sort of seeking this ideal of motherhood, perinatal women with ADHD are often determined to meet this unattainable or unrealistic ideal, more appropriately, not unattainable, just unrealistic, by masking symptoms. And so I think to understand women with ADHD, we cannot underestimate the extent to which women measure their self-worth and self-esteem according to their success in conforming to these expectations. And then you throw in the reality of all of these novel demands as women adapt to caring for their babies during a time of changing hormone levels and sleep disruption. Being an effective mother includes an incredible amount of executive functioning, getting and staying focused with, for example, like school forms, back to school checklists, parent-teacher communications, modulating attention, right? So you're doing something and the child falls and needs a Band-Aid or soothing now, despite dinner being on the stove. Regulating emotions. Young children and older children can be incredibly dysregulating of our own affect. And so the ability to regulate and modulate our limbic system in response to an out of control and emotionally reactive toddler, infant, or older child means that women have to work extra hard to remain calm and not yell back and get dysregulated themselves. Controlling impulsivity, utilizing executive function skills. Remember, I have a patient who talks about filling her cart and then never completing the purchase, and then realizing that the diapers and the wipes and the labels and the sippy cups just never got there despite best intentions of filling the cart. So the specific components that make up this collection of regulatory functions include the ability to initiate behavior, to inhibit competing actions or stimuli, to select relevant task goals, to plan and to organize in terms of, various demands on your time and needs, to sustain attention and effort, and to shift also strategies on the fly when needed. So women with ADHD struggle with a lot of these domains. And yet to date, this particular population, mothers with ADHD, has not received, I would say, the attention and systematic study that it deserves. Some studies do exist in terms of mothers with ADHD. In this study of first-time pregnant women, high levels of maternal ADHD symptoms were related to less positive expectations of parenting, less perceived control about parenting, and less attendance at prenatal exams. In this study, it was a meta-analysis looking at parental ADHD and parenting behaviors, and highlighted that parental ADHD is associated with more harsh and lax parenting, less positive parenting, greater overreactivity with children, and lower parental control and satisfaction by both self and also collateral reports. And studies of mothers with school-age children with and without ADHD show a similar pattern of finding among those with ADHD. Further, in this particular study, women with ADHD experienced difficulties with parenting during early childhood, specifically due to weaknesses in impulse control of attention, and hyperactivity compared to controls. And then this review comprehensively covers the relation between parent ADHD and child ADHD treatment outcomes. So it articulated that clinical phenomenon that we often observe when working with pregnant and newly postpartum women with ADHD, namely the executive function aspects of parenting, like planning, organization, routines, supervision, and flexibility, which are linked to inattentive symptoms and poor executive function. All of these contribute to increased chaos in the home. So we took that sample of women that we had followed longitudinally during pregnancy, and then we evaluated them in the postpartum. By that point, we had fewer participants with data that was able to be analyzed. So the results are based on analyzed data from just 17 women, an incredibly small number, but nonetheless, so interpret with caution, and from a statistical significance perspective, hard to do the analyses with such a small data set. That being said, it was interesting to see that in the postpartum, there was a significant difference in reported attentional symptoms. So this is different from what we had observed in pregnancy. In the postpartum, women showed a significant difference between their first visit, which was postpartum, I think, week 6, to their third visit, which I think was postpartum week, around 20, so about 5 or 6 months postpartum, having a higher value on their ADHD symptom scale. And then likewise, self-concept, women were more likely to have specifically negative self-concept in the postpartum than they were at the 6-week postpartum visit. So in conclusion, women experienced an increase in ADHD symptoms in the postpartum period, as well as functional impairment, including negative self-concept. So putting it all together in terms of thinking about what to do, although historically the default medical position is to interrupt any what's considered non-essential pharmacologic treatment during pregnancy and breastfeeding, in ADHD, I would propose that this may present a significant risk. And many patients, in my experience, have decided to minimize exposure to ADHD medication during their pregnancy and optimize their treatment postpartum. But for those clinicians on today's webinar, I think our role is to evaluate each case carefully and do an individualized risk analysis with our patients in the consultation room prior to developing a treatment plan for pregnancy. So in other words, there is no one-size-fits-all model. And at the same time, we can do individualized treatment planning because we have a lot more data on various medications and also course of the disorder during pregnancy and the postpartum. What about hormones in terms of what do we know, and how does this then factor into our consideration of the treatment of women in motherhood with ADHD as they get their periods back, as they breastfeed, as they consider hormonal birth control, as they plan for another pregnancy, and then in later years as they enter the menopausal transition. The literature that is available on the relationship between sex hormones and ADHD is limited, and available studies present sometimes contradicting information, which is confusing and frustrating. However, and it is not known how this lack of evidence affects the treatment of ADHD during the lifespan, with, of course, a call for further research that is required, I would say, to correctly characterize all the various mechanisms behind exactly how ADHD symptoms manifest in their potential association with sex hormones. But we do know a fair bit. We know that boy and girl fetuses are subjected to high levels of estrogen in the uterus in the early phases of brain development. We know that after birth, both male and females produce estrogen. But then females have about 3 to 10 times the level of estrogen as males until the years leading up to menopause. So it is in girls especially, and in the context of pregnancy, the postpartum, all the hormonal events that I just listed, breastfeeding, your period coming back, subsequent pregnancies and or miscarriages, resuming hormonal birth control, and the menopausal transition, that we must consider the effects of higher levels of estrogen and also fluctuating levels of estrogen, changing levels on brain maturation and functioning. So I tried to do this in this summary graphic representation, just showing estrogen and dopamine and how they all come together. So receptors and binding sites are important to think about because the more receptors we have in our brain, the more responsive our system will be to even a small amount of a neurotransmitter like dopamine and norepinephrine. So it's relevant to see that bottom line there, that estrogen increases available, it enhances existing dopaminergic receptors. And in conditions like ADHD or depression, if the neurotransmitter level is low, having more receptors or enhancing the sensitivity of those receptors, like turning up the volume, can lead to a decrease in symptoms. So we also know that estrogen can increase production of dopamine and increase, or rather decrease the breaking down of the dopamine, the sort of recycling of the dopamine, the reuptake and the recapture. So these two chemicals are incredibly interrelated and relevant when we're talking about ADHD, pregnancy, and motherhood. We know that the female brain is sensitive to low estrogen conditions. So, for example, premenstrually, postpartum, and also perimenopausally, this is a time where we're more likely to see mood swings, irritability, sleep disturbance, and other cognitive problems. And so it's these low estrogen states that may present this added burden for girls and women with ADHD post and then also perimenopausally, because the decreasing levels of estrogen seen at those times may in turn result, as I've outlined in this picture, in a decreased sensitivity or lowering of the volume of receptors in girls and women that are already compromised by lower levels of neurotransmitters like dopamine, norepinephrine, and serotonin, or by having smaller brain areas that are working at times when estrogen is lower, like your prefrontal cortex and the interconnecting subcortical areas. So a worsening of the symptoms of ADHD, along with an increase in mood disorders and even impaired cognitive functioning, may then be a result. So putting it all together, and I appreciated the title about a practical guide. considering pregnancy, you could think about this script in the consultation room with your doctor. And for the clinicians on the call or on the webinar, this is likewise a helpful framework to use when reviewing a woman's history and what her treatment is and how to think through planning for pregnancy. So this was actually by colleagues who had published a paper on this, and I just thought it was such a great practical offering. So, something like, "Hi, doctor, I'm planning to get pregnant within the next year. I'm wondering, what are your thoughts on whether I should continue my long-acting methylphenidate?" And the clinician could say something like, "That's a great question, and there's no right answer." Which, by the way, can, I think, be frustrating for a lot of people. I think the wish or the fantasy is that there's the right way and then there's the wrong way. And so best to do the right. And so if it hasn't been already clear that, there is no risk-free decision. And at the same time, I think doing tailored individualized approach can really mitigate risk and come up with the best plan for an individual. So in this response from the clinician, they could say something like, "It's best that we make the decision together, taking into consideration the severity of your ADHD and the potential negative consequences of you not taking your medicine, as well as compare that with a possible increased risk of, birth defects and or potential obstetric outcomes, like maybe high blood pressure versus other pediatric complications, maybe a need for a brief stay in the NICU, and then use that time as an opportunity to review the available data to date." And then, as the prospective pregnant person, you could say something to the effect of, "Well, what are some of those risks?" And then the clinician can, use that time to review some of the recent studies that show potential associations between use of medicine and cardiac malformations, particularly ventral septal defects, maybe with methylphenidate. But again, the absolute risk is low. And one way we can thread the needle is by getting a fetal cardiac ultrasound. And I think it's worth noting and stating in the consultation room that there are a lot of confounding variables in these studies, which means that no study is perfect. And there can be confounds like the population being studied is very different from you. For example, you may not have any medical comorbidities, you may be a non-smoker, and there may be other variables that make your unique situation very different from the population that was studied and described in that particular research report. So then what about now that you're pregnant and or newly postpartum, how do we think through mitigating risk? So how do we sort of thread the needle between driving safety, impairment in fulfilling occupational and domestic roles, as well as minimizing risk of exposure unnecessarily to medications in pregnancy and in the postpartum. And so this is where really you can consider reducing your workload if that's an option. If you haven't already done CBT for ADHD or availed yourself of organizational skills or executive function coaching or training, that can be very important to do. Thinking through how to restructure your environment, linkage for support to coaching and or support groups. Remembering that it's important to validate your experience and question the impact of societal expectation and practice self-advocacy. So with that, medication being a piece of it, but not the entire story. And so pregnancy is often a great time to optimize those other facets of treatment if they haven't already been done so to date. And then what about practical guide now that you're in the postpartum and have a young family? How can you take the best care of yourself possible? And this is where my message would be to double down on proven effective ADHD treatments. We know that motherhood and parenthood can be a time of incredible highs and lows, a lot of chaos, can be environmentally overstimulating, and that can lead to increased cortisol, which can have impacts on both ADHD symptoms as well as the comorbidities. So this would be a time, again, to really emphasize the prescription of exercise, considering home organizational support or organizational skills training, executive function coaching, mindfulness-based stress reduction, CBT for ADHD, as well as time in nature, regulating sleep, access to excellent nutrition, and practicing general self-care. And then finally, practical guide managing ADHD as a mother. I think it's worth noting that women of reproductive age with ADHD would benefit from working with a psychiatrist or a medical team who really is open to learning and or understanding, if they don't already do so, the impact of hormones on ADHD throughout the lifespan and the way in which it interacts with medication. So for example, as we discussed in the slide, with the brain and the estrogen and the dopamine, stimulants may be less effective during the second half of your menstrual cycle. And hormone replacement therapy can really improve ADHD symptoms in postmenopausal women. So these are factors worth considering, and hopefully points of discussion that you and your physician can have together, your medical team. And working with an integrated and informed and supportive healthcare team is essential and can lead to better outcomes for women. So that concludes my remarks, and I look forward to, I hope, a lively discussion section.
Thank you. So before we start the Q&A, I'd like to thank Inflow once more for sponsoring this webinar. I'd also like to share the final results from today's poll question: which of the following ADHD-related challenges has had the biggest impact on your decision to become pregnant? 26% cited concerns about managing ADHD symptoms without medication during pregnancy. 25% said concerns about the potential impact of ADHD on parenting ability. 19% said concerns about the potential impact on ADHD on the child's development. 13% said concerns about managing medication for ADHD during pregnancy. And 10% said concerns about the financial impact of managing symptoms and treatment during pregnancy and parenting. So now to the questions. We had quite a few questions around preeclampsia. So if you have a family history of this, or you're at an increased risk due to racial demographics, is it wise to continue medication use during pregnancy, given the small increased risk that was borne out in the studies you had mentioned?
It's an excellent question, and one that I think is sort of best answered by, perhaps the frustrating response of "it depends," but certainly something of relevance to discuss not only with your psychiatrist or psychiatric prescriber, but with your OB. I have many colleagues who, in obstetrics, who will just monitor women more closely and more frequently. For example, in earlier parts of pregnancy where they might otherwise just be coming in for a monthly visit, they may be coming for weekly just blood pressure checks and or urinalyses to more closely monitor blood pressure and associated risk for preeclampsia. So it's not necessarily a contraindication to you continuing your stimulant medication during pregnancy, and likely an indication for you to be more closely monitored by your obstetrician.
In the studies, it cited exposed. So there was some question about what exposed meant. So does exposed mean that mom continued to take meds at the same frequency that she did before pregnancy or during pregnancy? Or does it mean any exposure to meds at all? Can you clarify that?
Yes, sure. And thank you for that clarification question. So in general, the language exposed and I don't know which study that particular question was referring to, but it typically means exposure to medication. And so the medication that we're talking about today would be stimulant medication, unless I otherwise indicated, which I don't think I spoke about sort of any of the reproductive safety data about other medications. So that would have meant women who continued to take psychostimulant medication or medication for the treatment of ADHD during pregnancy.
Okay. We also had questions around taking medication during breastfeeding. Mm-hmm. So Are there risks associated with that specifically, or does breastfeeding follow the studies? Or could you talk a little bit about that?
No, I'm glad. Yeah, I'm glad that that someone has asked about breastfeeding. So we don't have as much available data for transfer into breast milk of the different medications, but we also have some. We have case report data or case series data, which basically is most of what we have actually for breastfeeding on medications at all. And so what we know is for amphetamine derivatives, the relative infant dose when breastfeeding on Adderall is low. And the relative infant dose when breastfeeding on methylphenidate or any of the methylphenidate derivatives is very low. So many cases like less than 1%, when less than 10% is considered low. Women will resume often stimulant use in the postpartum and including while they're breastfeeding. And so one consideration is not necessarily worrying about word again of the infant to the medication in the breast milk, but rather also the overall sort of biosocial rhythm of the mom in the acute postpartum. For example, if taking stimulants means that she can't also rest and sleep, especially when the baby's sleeping, which is often a recommendation, that might be a reason to consider refraining from using the stimulant so that you can take a nap when the baby's sleeping. But I have many patients and many women who elect to optimize, to kind of resume their medication in the acute postpartum to help manage life with a newborn, and then certainly at the transition point of back to work, while also breastfeeding. So we have, as I said, case report and series data that's overall reassuring for most of the stimulant medication.
Is there a link between ADHD and miscarriage, endometriosis, and or infertility?
The first part, yes, I had mentioned that there has been an association between ADHD and miscarriage that was shown in some of the studies looking at methylphenidate specifically, that it had been suggested that perhaps it was the methylphenidate exposure that had led to the increased rate of miscarriage. And again, we're talking pretty small numbers, but nonetheless, worth considering. But then there was the study that showed that even women who stopped their medicine but had the disorder likewise had that slight increased but statistically significant increased risk of miscarriage. Again, I think it's important to take that data into the broader context of what else was going on with that particular population, and does that apply to me? So, for example, one of the most known vulnerability factors for any kind of obstetric complication is smoking tobacco. And so if that particular variable is not controlled in those studies, and some of those studies that was not looked at, then that would be what I would say is sort of a confound that makes that data maybe less relevant for you if you are someone who is a non-smoker, who's never been a smoker, and attending all your prenatal care, and you're taking your ADHD medication as prescribed. That would be favorable in terms of mitigating or lowering your risk for miscarriage. So we don't have, data saying that it's, a significant concern. And at the same time, I would advise and recommend that, your overall health status and specifically your smoking status would be the most relevant variable to consider. So if, planning pregnancy, discontinuing tobacco use would be one of the best things you can do for yourself, along with taking a prenatal vitamin.
Speaking of prenatal vitamins, we had the question, can you recommend vitamins or supplements to support pregnant women in the absence of stimulant medication use?
That's a great question that has not been studied systematically. So we don't have any studies looking at specific sort of vitamins, minerals, or prenatal vitamins for the treatment of ADHD in pregnancy. That being said, any prenatal vitamin that has sort of what the CDC makes recommendations for, including folic acid, anything else that would be in a prenatal vitamin would be great to start. Honestly, anytime you're even thinking about getting pregnant, because the more that you can beef up your folic acid reserves, your folate reserves, the better. That's something that can be started, even as you're just starting to contemplate whether or not pregnancy is on the horizon for you. And I'm not sort of wedded to any particular manufacturer of the medication. I would just say, practically speaking, it should be one that you can tolerate, doesn't make you feel nauseated, and therefore that you're more likely to take every day.
Someone writes, I'm a perinatal mental health counselor, and I often have new moms self-diagnosing ADHD from social media content. How can we help women differentiate between postpartum presentation of anxiety and ADHD?
That's a great question, and also brings into the mix the complexity of, social media sort of expertise. I would say, this is it's a good question to look at clinically and systematically with rating scales and taking a careful history and involving the partner and kind of looking retrospectively at the ADHD profile versus something that's happening sort of acutely in the postpartum in the context of sleep deprivation and changing hormone levels and sort of novel demands of infant care that, of course, would, can either exacerbate underlying anxiety vulnerability or create it for the first time. So I think sort of being measured, validating, listening actively, and then also engaging in an appropriate and systematic evaluation of whether or not, this makes sense and is best understood under the heading of an ADHD vulnerability versus anxiety or otherwise.
And then the last question has to be, do you have recommendations for discussing your desire to continue medications with an OBGYN who may lack current knowledge or have internalized stigma of ADHD or quote unquote drug-seeking behavior?
I do. So I think that, knowledge is power. So being able to come to a consultation with available information and reviewing the studies, not that that's your responsibility. And at the same time, the reality can often be, and I hear this from patients every day, that often they're the most knowledgeable person in the room when it comes to the nuances of their particular psychiatric disorder and or the reproductive safety of their medication, the course of illness of their psychiatric disorder. So one resource that is terrific is our website, which is the Center for Women's Mental Health.org. My colleague, Ruta Nonax, is our editor-in-chief, and she is philanthropically supported to review every single study, paper, review, meta-analysis that comes out, and then essentially translates it into English for the rest of us, myself included. And she does a phenomenal job and does it weekly. So that's a great resource. It's womensmentalhealth.org. And there are all kinds of what she calls the essential reads, or she does a weekly roundup. And that is a great resource both for you as well as potentially your clinician, including your obstetrician, who just may not know, who maybe went to medical school a long time ago when ADHD was considered non-existent in girls and women. And today, obviously, it's a very different story. So it's an opportunity for education, which may feel frustrating, and I validate that. And then if there's a provider who's just, ill-advising you or the vibe is not right, you can certainly seek consultation elsewhere. And it's important that you do so because it's a long relationship in terms of the sort of pregnancy planning and the 10 months of gestation and the postpartum journey. So if you have the option to look elsewhere, I would advise you can do that if you're feeling like this particular person is not sort of responsive and open to discussion about your particular medical needs.
Well, thank you, Dr. Baker, for joining us today and for sharing your expertise with our ADHD community. Make sure you don't miss future Attitude webinars, articles, or research updates by signing up to receive our free email newsletters at attitudemag.com/newsletters. If you're listening in replay or podcast mode, visit attitudemag.com and search podcast 454 to access the slides, the video replay, their certificate of attendance option, and the webinar transcript. And if you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe. Thank you, everyone.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.
Ever tried reading while jogging, cooking, or even juggling flaming torches? Yeah, it doesn't end well. But with audiobooks.com, you can conquer books without the circus act. Dive into over 450,000 titles, including more than 10,000 free ones. Get hooked on a bestseller, find your next obsession, or finally read that classic you've been avoiding since high school. And here's the inside scoop. Sign up today for a free 30-day trial and snag your first 3 audiobooks on the house. Sign up for your free trial at audiobooks.com/podcastfree today. That's audiobooks.com/podcastfree.